Hello, this is Robert Lee, and this is a brief video outlining the epidemiology, natural history, and risk classification of localized prostate cancer. We'll briefly review the epidemiology, natural history, and risk classification. Most of these data are taken from the American Cancer Society website. In 2020, approximately 190,000 men will be diagnosed with prostate cancer, and just a little over 33,000 will die. You see the incidence rates for newly diagnosed disease and death rate. And so extrapolating these over a lifetime, 1 in 9 men will be diagnosed, and 1 in 41 men will die of prostate cancer. So a very large difference between the incidence and the death rate. This is the trend in incidence rates over the last 40 years. The spike that you see in the early 1990s is related to the widespread utilization of PSA screening. Anytime a screening test is introduced into a population, you have a large spike. These are the trends in death rates over the last nearly 100 years. The decrease that you see from the early 90s to now, it's difficult to say for sure, but it's likely some of it represents early diagnosis and some of it represents treatment, but it's very difficult to tease out exactly what is responsible for what. These are the 5-year survival rates reported on the website, looking specifically at localized and regional disease. Nearly 100% of men survived the first 5 years. From a clinical standpoint, this highlights that in non-metastatic prostate cancer, 5-year survival is essentially a meaningless outcome. This is the incidence and death rates of prostate cancer according to geography. You'll see that there are hotspots for the incidence in the southeast. This is largely related to the racial demographic makeup of that region of the country, and the death rates you see do differ quite dramatically between some states and others. I referenced the racial ethnic disparities in both incidence rate and death rates. Here they are. African Americans or non-Hispanic blacks have a much higher incidence of prostate cancer and death rate of prostate cancer. We're going to look at a few autopsy series here. Many men have occult prostate cancer. This is a series from now nearly 30 years ago, taken from Wayne State, looking at young men, less than 50, and looking at their prostate. The incidence of prostate cancer in the second and third decade is very low, but begins to make an appearance in the fourth and fifth decade. This is particularly important as this population is overrepresented with African Americans. Looking at larger autopsy series, this is a comprehensive analysis of more than 6,000 men who underwent autopsy, and looking for prostate cancer, you can see the trend for increasing incidence of prostate cancer in the prostate as men age. And you can also see the dramatic differences again in prostate cancer according to race. A few slides on natural history. This is, I think, the best natural history paper that we have. It's a registry-based cohort study from Sweden. More than 75,000 men. All of these men have been observed. No curative intent treatment has been performed, And we have long-term outcomes, 10 and 15-year cumulative risk of death, and stratified, importantly, by the risk categories that we'll talk about in a few slides. A lot of information on this slide. The takeaway is that in orange on each one of these is prostate cancer, cardiovascular disease is in blue, and green is other mortality. So broken out by risk group in rows and according to age in columns. And to show you the extremes, in men who are older, over the age of 75 at diagnosis with low-risk disease, mortality due to prostate cancer, although measurable, is dramatically overwhelmed by cardiovascular disease in particular and other diseases. So this is supportive of the idea that most men with prostate cancer die with it rather than from it. At the other extreme, if we look at high-risk patients who are young at the time of diagnosis, here prostate cancer is much more of a problem as far as mortality as related to cardiovascular disease and other disease. So it very much depends on the risk of the cancer itself and the age group. Again, I want to emphasize this is non-curative. None of these patients received curative therapy. So now let's look a little bit more in detail at risk. Well, if we're considering definitive treatment in men with prostate cancer, the first thing that we need to consider is their age. No one is mortal. Overall life expectancy throughout the 20th and 21st century in general has been increasing, such that the average male who's 75 years of age has 15 years left in his remaining lifetime. This is dramatically different than when I began in practice in the 1990s, where a 70-year-old had a 15-year median life expectancy. It's now 75-year-old. And so when we're considering treatment, we need to consider underlying mortality due to other diseases, and we also need to consider the underlying mortality of the disease itself, that is prostate cancer. This slide highlights just a few of the many different risk groups and nomograms that are used to try and predict prostate cancer mortality. They range from very simple, straightforward risk groups to more complicated nomograms. The D'Amico risk stratification system was initially described in 1998. It classifies its patients into low and intermediate and high-risk groups based on PSA, Gleason, and T-stage. Many other groups have jumped into the game themselves and have also developed risk groups. Most of these risk groups were initially developed based on biochemical endpoints. The nomograms are more complicated. They rely on additional information, and normally you need a calculator. For the risk groups, usually based on your clinical information, you can put a patient into a box, and the nomograms basically involve putting information in and then calculating a risk. Only recently, a large study has looked at how these risk classification schemes and nomograms compare with one another. This is a particularly helpful study, in my view, in that it's a population-based study looking at prostate cancer death using the concordance index to determine which of these different systems are best at prediction. So the higher number in a concordance index means it's a better predictor. You can see in general that the nomograms are a little bit better at predicting. Now the trade-off is that the simple classification schemes, D'Amico is the one example, that is something that just about anyone can do based on T-stage Gleason score, and PSA. Some of the other risk classification systems are more granular, looking at positive biopsies, 4+3 versus 3+4. And so you do get, as you get more information and it gets more complicated, you do get a little bit better prediction. Whether this has any clinical utility, it's yet to be proven. So pick one that you're comfortable with and try and use it consistently. The new kids on the block are these genomic scores, genomic tests of various types that have been added to normal clinical pathologic risk classification schemes, and in general add a little bit of predictive information. Whether the additional cost is worth it has yet to be demonstrated, particularly as it relates to important outcomes like prostate cancer mortality and overall survival. So the value, if you will, of these have yet to be demonstrated. So take-home points: prostate cancer is a very common disease. There are significant racial disparities in incidence. Usually, it is not a lethal disease, particularly in older men with lower risk disease. We also have racial disparities in mortality. Risk is quantifiable using a number of different systems. And to date, the genomic tests, although promising, have not been proven. Here are some resources that you can use to go to the primary source documents. Thank you.